The present strip is taken from a 60-year-old heavy smoker man, presented with progressive pitting edema and dyspnea since 6 months ago. What do you think about this strip? Which of the following is the correct answer? 1. Right bundle branch block. 2. Cor-pulmonale. 3. Old anterior MI and ischemic cardiomyopathy. And 4. Posterior MI. At this point, pause the video to interpret it on your own, then we go through it together. As usual, to interpret every EKG tracing flawlessly, use the 10-step approach. First, start with standard values. In the present strip, the calibration marker is 2 mm tall and 1 mm wide, so this is a standard and acceptable strip. Next is determining cardiac rhythm. There are sinus P waves before QRS complexes. There is no dropped beat. The PP interval, PR interval, and RR interval are stable. These findings establish normal sinus rhythm. Then we should go through the heart rate. There are 4 large boxes between consecutive R waves, so the heart rate is nearly 75 beats per minute. The fourth step is axis determination. The QRS complexes are negative in D1 and positive in D2, so the axis is deviated rightwards. Next thing is examining waveforms and intervals. As we already said, the P waves are sinus. They are obviously peaked and greater than 1.5 mm in V1 and V2, which favors P pulmonale. Remember that P wave amplitude greater than 2.5 mm in D2 or 1.5 mm in V1 suggests right atrial enlargement. For more information about atrial enlargement, tap the link in right upper corner. The PR interval is about 4.5 small boxes, which is considered normal. How about QRS complexes? There are several important changes in QRS complexes. There is QR pattern in V1 with deep S wave in V6, R wave is prominent in V1 and small in V6, so the R wave progression is somehow opposite. The complexes are narrow and have normal voltage as well. In summary, reverse R wave progression and prominent are in V1 with deep S wave in V6, are abnormal changes of QRS complexes. Among all abnormal findings in this strip, tall R wave in V1 is the most important. Tall R wave is defined as an RS ratio equal to or greater than 1. It can be a normal variation in less than 1% and has several important causes. RBBB, RVH and hypertrophic cardiomyopathy, posterior MI, WPW pattern, dextrocardia, and muscular dystrophies are differential diagnoses of tall R in V1. In this strip, RVH is the cause. You might think that tall R wave in V1 with concomitant deep S wave in V6 are due to RBBB. But note that QRS complexes are not wide at all, so RBBB is not present here. We will talk about diagnostic criteria for RVH at the end of the video. The QT interval is about 9 small boxes. According to Hodge's formula, corrected QT or QTC is about 386 millisecond, which is within normal ranges. Next step is examining STT wave changes. There are ST depressions in V1 to V5 and inferior leads. T wave inversion is present in V1 to V5 as well. Remember that ventricular hypertrophy can be an important cause of STT wave changes. The last thing is overall interpretation. To interpret every EKG perfectly, we should make a list of abnormal findings. RA enlargement and QRS changes due to RVH are the only abnormal findings in this strip. Many criteria have been defined for RVH. In general, all criteria are classified into 2 main categories: voltage criteria and non-voltage criteria. RS ratio in V1 more than 1, or RS ratio in V6 less than 1. R wave more than 6 mm in V1, or S wave smaller than 2 mm in V1. S wave more than 5 mm in V5 or V6, or R wave smaller than 3 mm in V5 or V6. R wave more than 5 mm in AVR. And some of are in V1 and S in V5 or V6 exceeds 10.5 small boxes, are well-established voltage criteria for RVH. Non-voltage criteria for RVH include right or extreme axis deviation, deep S wave in D1, D2, and D3, which is so-called S1, S2, S3 pattern, P-pulmonale, and QR pattern in V1. In our strip, QR in V1, right axis deviation, and P-pulmonale are non-voltage criteria that favor RVH. Additionally, the ratio of R to S wave in V5 and V6 is less than 1, and S wave in V6 is more than 5 mm as well. All these findings are highly in favor of RVH. Note that, in patients with RVH, QR pattern in V1 favors cor-pulmonale. Cor-pulmonale is a condition that causes the right side of the heart to fail due to chronic lung disease. So, according to patient's medical history and EKG findings, our patient is suffering from cor-pulmonale, possibly due to COPD and long-standing smoking. Thanks for watching this video. If you are interested in challenging EKG cases, subscribe me and ring the bell. Have fun!